Good morning, everyone. At the outset, I would like to thank Rima for giving me an opportunity to share our experience, SPRT in breast cancer. So I'll be talking about like introduction and cyberknife and our experience. As we know about that, the SBRT is the in thing. It is we are looking at a small target with the eye dose, with the eye effectivity and eye precision, and that's what we are looking at in SBRT. So SBRT is effective. There is a we now especially we are looking at abscopal and immunomodulatory effect. The linear accelerator based the SPRT can be done in any of the platforms. I use CyberKnife. There is nothing but a robotic assisted radiosurgery. I don't want to go detail into this. There is a small video where, so basically we are looking at continuous tracking, continuous, continuous treatment. And here we are looking at even the smaller to the larger volumes can be treated. We fractionate, and wherever there's a soft tissue involvement, we track with the help of the fiducials. So there's a continuous tracking, with eye precision radiotherapy with submillimeter accuracy. So CyberKnife is having eye precision tracking, motion management, and eye dose delivery and rapid dose fall and patient friendly. So we have done for the past around 12 and a half years. There is around 4,000 patients we have completed, and breast especially there are around 400 cases. So how we do a complete clinical history and clinical examination is important. We do biopsy, immunohistochemistry with all molecular markers and genomics as and when required. MRI brain screening is essential in case of triple negative breast cancers. MDT discussion is important. When to include the SPRT is very, very important. So different scenarios of the SBRT. So the primary breast, we can treat the primary breast in a certain selective patients. APBI is another thing which is CyberKnife has become popular. So for the microscopic disease, I have my own concerns. So metastatic residual breast cancers, metastatic sites, oligometastatic sites, low volume and high volume both, and exploration of immunoradiotherapy. So we have I have contributed for almost around 200 cases. So brain metastasis is around 114. The most of the patients usually they comes with see a breast with brain metastasis. SBRT is very, very effective. Multiple sites treated, like it's 53 patients, and lung mets, liver mets, and spinal mets. Re-radiation in around 34 cases. A case scenario where the elderly female with the CA breast, she was not willing for any surgery, treated with the CyberKnife and put her on hormones. Recurrent breast cancers in the post-treated case, treated with the CyberKnife. So these are some of the rare scenarios. And usual scenario is where like CA breast treated in 2010, she was on follow-up, she was on hormones for 5 years, then she stopped. And 2020 January, single lung metastasis, treated with CyberKnife and put her on hormones again, no chemotherapy for this particular patient. So you can see the response and post-treatment changes, very well tolerated. And there's another patient, CA breast with brain metastasis to start. We treated brain mets and continued the chemotherapy initially, and she developed the metastasis over a period of time. And like we treated the liver and the local area after 2 years, and she continued the chemotherapy, the second and third line. But like the areas where we treated responded very well. She succumbed to the disease in 2019. She was almost around 5 years survived. The another scenario is where the patient was treated with metastatic breast cancer, treated with chemotherapy. All the metastasis has disappeared except for one particular one. We treated with CyberKnife and put her on hormones over a period of 5 years. For four different places, the metastasis occurred. We treated in these in a different timeline, and with a good local control, almost 90% local control. So there's another scenario, the mediastinal nodes. This is where see a breast with mediastinal nodes is one of the common things. They after chemotherapy we treated with the residual area and the liver lesions with SBRT. So whenever there is a multiple metastasis, we give whole brain followed by the cybernetic boost and treat the other areas. If it is less than five in number, we do with SBRT alone. Abscopal effect and the immunotherapy exploration of the immunotherapy is in things. We have some experience with the lung cancer and the prostate cancer. We have published our data. So there are two patients I have done where the patients have completed the chemotherapy and there is no other lines of chemotherapy. They exhausted the chemotherapy, and this is where the patients had a mediastinal node and the liver and the lung lesions and the brain lesions. We treated with the immunotherapy to this patient, and for our surprise, the cyberknife and immunotherapy, there was a almost complete response. She survived for another year, and she succumbed to the disease. The patient actually failed with multiple brain metastasis with severe disease of spread. So these are the different scenarios. We are publishing our data. Um, uh, like to conclude, actually, SBRT is an effective as a modality for APBI. We can include it for especially in oligometastatic setup, even in the low volume and high volume should be considered for SBRT. And as much as possible, treat the primary area that is most important in case of breast cancer. Abscopal effect and immunotherapy should be explored in a big way. Thank you for your patient hearing.